So anyway, good evening. So for the case studies this evening, I have chosen some of the common and very simple scenarios that we encounter in our daily practice, not just for cardiologists, but also for physicians, general practitioners who are in the audience today. So my first case is a 55-year-old lady, a diabetic, a hypertensive and borderline coronary artery disease. She had an angiogram, was diagnosed to have 40 to 50% borderline lesion in LAD, was kept on medical management, and now she's come to you with an LDL of 150 milligrams per deciliter. She's already started on simvastatin 40 milligrams per day. And then she develops, a couple of weeks after starting the statins, she developed severe proximal muscle pain, which is disrupting her daily lifestyle. Her CPK was checked, it was normal. And the other causes of muscle pain in these patients like arthralgia, arthritis, and the concomitant medications which can cause these kind of symptoms, everything is ruled out. We've also asked about her whether she takes alcohol. Excessive alcohol when combined with statins can sometimes cause myalgias, but she doesn't consume alcohol. So now what should we do? Whether should we continue simvastatin? Let's just say this is just myalgia, CPK is normal. We don't want to stop the statin because she has coronary artery disease. Or should we switch to an alternative statin? If you would switch to an alternative statin, which one is it going to be? I would like this to be a little more interactive. So how many of you would continue simvastatin? Anybody lift up your hands? Nobody would continue simvastatin. Oh, there's one. Okay. So how many would switch to an alternative statin? There's about 3-4 of them. Well, what about the rest of you? Anyway, let's see what happens. So there are some statins which are called lipophilic statins. These are statins which concentrate themselves more into the extrahepatic tissues like muscles and the peripheral tissues, which are often associated with myalgias. Like simvastatin, for example, is a lipophilic statin. So switching to hydrophilic statins like rosuvastatin, pravastatins would ideally cause less myalgias in these patients. So then this patient is switched to rosuvastatin 40 milligrams per day and started feeling a little better. But however, she comes back to you saying the symptoms of myalgias are still persisting. So at this juncture, how many of you would reduce the dose of rosuvastatin or switch to an alternative statin? How many would reduce the dose of rosuvastatin? Show of hands. Okay, thank you. That's good. Yes, majority of you would reduce the dose, which is the right thing to do. So we have cut down to 5 milligrams of rosuvastatin per day just to observe the symptoms. By the way, unless you have tried at least the lowest dose possible of at least 2 statins, you cannot diagnose a statin intolerance. So the lowest dose of a rosuvastatin is 5 milligrams. So we kept this patient at 5 milligrams. And then after a couple of weeks, this patient comes back to you with, again, symptoms of myalgias and pains. Now at this juncture, how many of you would stop statin? How many of you would go for an intermittent statin dose? Remember, this patient is also diagnosed with coronary artery disease, and statins are not used just for reducing your cholesterol. They also have pleomorphic effects. That means they're going to stabilize the plaque which is in the artery. They're going to reduce the chance of erosion of the plaque. They're going to reduce the plaque rupture. They're going to improve the endothelial function. So statins are very, very important in this patient, not just for cholesterol, but also for their pleomorphic actions. So stopping a statin perhaps is not the best thing to do, and I'm sure all of you would switch to using intermittent doses of statins. And in some of the studies, actually intermittent doses of statins worked very well in reducing not only the LDL cholesterol, but also the cardiovascular outcomes have significantly improved even with intermittent dosing of a statin. So this patient was given intermittent rosuvastatin 2 to 3 times a week, well tolerated. After 4 weeks, patient comes back to you, she's doing well, but her LDL target is not achieved. She's still, LDL is about, say, 120, 130. So you decided to increase the dose. Anyway, now she's tolerating a statin well. After all, statin intolerance is largely contributed to an immunological reaction. Sometimes they just disappear. So you increase the dose and make it to daily once, maybe 20 milligrams, let's say. So after a couple of weeks, patient again comes back to you with severe muscle pain, dark colored urine, and this time her CPK is elevated to 2,500. So what would you do now? Would you stop, wait for all this to settle down, and restart the statin after patient is better? Or now do you think it's time to consider alternative therapies? How many of you would straight away go for alternative therapies? Okay, that's good. And can any of you tell me what is happening to this patient at this point of time? That's right, rhabdomyolysis. The rhabdomyolysis is a very uncommon complication of statin. It occurs nearly in 1 in 100,000 patients treated with statin. But when it occurs, it's a very dangerous complication. It could cause renal shutdown and acute renal failure. So the statin has to be stopped immediately, and you have to get a nephrology consultation and dialysis to tide over if required. And patient, perhaps this is the only indication that the patient is now better not to be on statin. Patient has to be stopped from taking any further doses of statin. This is one of our publications of an important case of a lady presenting with acute myocardial infarction after PCI, started on statin dose and developed rhabdomyolysis. And the indication, the early indication was hyponatremia. When you see the initial dose, stage of patient developing a suspicion of rhabdomyolysis comes when the patient starts developing muscle pains and the sodium goes up. Okay, so now this patient is taken off statin and the alternative medication is considered, which are PCSK9 inhibitors, bempedoic acid, or ezetimibe. I'm not going to go into the details of this medication for the lack of time. And I'm going to quickly move to another interesting case of a 27-year-old gentleman. He presented to you with dyslipidemia. His LDL is about 160, and he recently had an MI, underwent angioplasty, but he's not a smoker, not a diabetes. He has no diabetes, no hypertension. His father had an MI, but he had the MI at 65 years of age. And his BMI is 23.5. That means it's well within the normal limits. He exercises daily. He's on cardiac medication with optimal dose of rosuvastatin. Now, he asks you, why is my LDL is still high? And what should I do to have a healthy lifestyle, to reduce my cholesterol? Now, of course, at this point, we would consider adding another drug to him, but remember, he's only 27 years of age, so adding one after the other, medicines one after the other may not be the ideal thing. We should tell them to do lifestyle and good diet changes so that his lipid profile is well within control with just probably 1 or 2 drugs. So what would we suggest? Just before I take you to further into this case, I want you to look at this very important picture. This is the picture of cholesterol metabolism. So all of you know that the dietary fats are absorbed from the intestine and carried in the blood vessels. At that point of time, some of the fatty acids are used for the muscle functions, and the rest is taken to the liver, where the various particles of LDL, VLDL, and other cholesterol particles are made and released back into the bloodstream and taken up by the peripheral tissue, used for various functions like hormone synthesis and so on and so forth. And the excess cholesterol is taken up by the adipose tissue and stored. Now, I want you to look at this picture and tell me where in this natural metabolism comes the stage where the cholesterol gets deposited to the arteries. In the natural metabolism of cholesterol, there is no stage where cholesterol gets deposited on the arteries. So if there is excess cholesterol, that is supposed to be taken up by your adipose tissue and be stored. So how are these atherosclerosis and other problems happening? And this is the reason. When the dietary fats are processed either by heat or chemical refining, various steps like neutralization, dewaxing, bleaching, deodorization, up to 13 chemicals are added into the oils that we are consuming. And when the fatty acids are bound to the chemical particles or whether they are oxidized, the receptors that are in the adipose tissue that are supposed to take up your cholesterol and to store are not able to recognize the cholesterol particles anymore because they're either bound by your chemicals or they're highly oxidized. This is a very interesting study that is published in BMJ Open Heart, which has brought forth this new hypothesis, which is the oxidized linoleic acid hypothesis. This is a meta-analysis. And what is linoleic acid? It is an omega-6 fatty acid, which is previously thought to be heart protective. This oxidized linoleic acid goes on to form the oxidized LDL and fatty acids, which are not recognized by the receptors for further metabolism. So they keep in the circulation and they're highly toxic to your endothelium. They damage the endothelium, then engulfed by the macrophages, form the foam cells which go on further to form the atherosclerosis. So high amounts of linoleic acid are found in the autopsies of humans who've died of heart attacks. And these high LA concentrations are found in seed oils, the vegetables oils, which are commonly used nowadays. And they're very low in olive oil and other fruit oils. This is another study, 7-year study, which again shows that the group which were on safflower oil or margarine from the vegetable oil had almost 62% higher rate of death and cardiovascular outcomes compared to those who were either on olive oil or butter. Said another way, these seed oils increase your risk of death more than either heavy drinking or moderate smoking. Again, another randomized, of course, these are all small studies, not yet come into the mainstream, but very interesting and innovative thoughts. A 2-year randomized control study, again, looking at margarine from the seed oil versus the olive oil, showed 7 times increase in cardiovascular outcomes. So now this to the patient, what would you suggest? He asks, the common questions they ask is, which oil should I use? What should I eat? What should I not eat? So we would suggest to avoid processed oils, refined seed oils, better olive oil or cold-pressed oil. So this means that we are eliminating the oxidization of the fats when they consume. Do I have time for another? Okay. I'm almost, my time is up, so I will not be able to finish the third case, but if there are any questions, I'm happy to answer.